All right, hello everybody. Welcome back for kind of our lunchtime webinar series. My name is Chris Urbanek. I'm a physician for Regenexx Des Moines, and today we're going to be going over kind of our thought process for knee osteoarthritis and the treatments that we can provide. So I am going to share my screen. Bear with me as I get the right one up, and we'll get started with our talk today. So kind of the first thing that we want to go over is basically the knee itself. So this is, I think, fairly familiar to a lot of patients, even just from exposure through their physicians and stuff that they read online. But this is an X-ray or a plain film radiograph of the knee. And just for some basic anatomy, the bone at the very, very top, this is the thigh bone, also known as the femur. The big one in the middle at the bottom is our shin bone or tibia. There's a little bone that kind of connects right next to the knee joint. It's our fibula, and that comes down to make up the outside of our ankle. And kind of hiding behind the thigh bone is our kneecap or patella. And so this is really the structures that we're talking about. And, where is the pathology, or basically what is arthritis? Let's just start with that. The word itself just means inflammation of a joint. And that can be for lots of reasons. In our realm of medicine, we primarily are dealing with osteoarthritis, which is painful, inflamed joint secondary to thinning of the cartilage. And so your question should be, well, show me the cartilage. Where's the cartilage in this picture? And you can't see it. And that's one of the things that I think is important to note, is that the cartilage lives at the end of both of these bones. And so between the thigh bone and the shin bone is a layer of cartilage. And we shoot these x-rays standing up, just like many groups do, because since you can't see the cartilage, you can infer its thickness based off of the x-ray in a weight-bearing view. So meaning that as this individual is standing, the space between the two bones, the only thing that's causing space between the two bones is the cartilage. And so the more cartilage there is, the more space there's going to be between the shin bone and the thigh bone, and the less cartilage there is, the closer the two are together. And now there's lots of other things that we look for. We look for small little osteophytes or bone spurs off to the sides of the joints. There are a couple small ones here. We look for the alignment of the kneecap, and we shoot multiple views. But my point is really like this is it. This is the thing that we're talking about when we talk about knee osteoarthritis. And there's really three kind of articular surfaces. You can think of them as joints, but really the whole thing is the joint. And so that's the inside of the thigh bone and the shin bone, the outside of the thigh bone and the shin bone, and the articulation between your kneecap and the groove that it sits in on top of the thigh bone. And so you can get osteoarthritis in any of these areas, and sometimes one area might be more symptomatic than another. So in this individual, if we kind of look at the inside of the joint, the medial side here, this space is certainly tighter than this space. So I would expect this patient to complain of more medial or inside of the thigh type pain. There are different views that we look behind the kneecap, and that can give us some information about the alignment itself, as well as the degree of osteoarthritis. And so maybe more of their arthritis is coming from a retropatellar source or behind the kneecap. And so this is basically it. This is the thing that we're talking about. And we're going to kind of go through what options exist for managing pain and increasing function with osteoarthritis. And I think, one of the areas that we're going to start with first is actually talking about some diet stuff. And so, when I speak with my patients, I often tell them, hey, my job to you is to be a good physician. It's to do a thorough exam, to understand you as an individual, to give you a good, solid diagnosis, and talk about all of the things that can treat your condition. If it's regenerative medicine or orthobiologics, great, that's my hammer. That's what I use to treat this. And if it's something else, then I'm going to send you to the person that does the something else on a regular basis and is expert at it. And so one of the things that can be done that doesn't require any intervention is the diet. And we know that there's a high rate of osteoarthritis in overweight or obese patients. And so it kind of makes sense from the mechanical standpoint, right? If you're carrying a heavier load, there's more stress on the joint. And the knee sees about 4 to 5 times your body weight with walking. So obviously there's a stress side to it. But even when we kind of take the stress, the mechanical stress of the knee joint away, we know that patients with increased body fat are more likely to get osteoarthritis. And in medicine, there's actually a couple other studies that I didn't include. We actually see patients that are overweight or obese that have a higher rate of hand osteoarthritis. And now these are not gymnasts that are walking around on their hands. It's because of the circulating levels of pro-inflammatory chemicals that make their way into the body. And so these are a couple of really great studies that talk exactly about that they've balanced for body weight and BMI, meaning that it's not a mechanical effect, it's the physiologic effect. One of them is leptin. And so leptin is one of our hunger and satiety chemicals that our body makes. And so whenever you eat, the leptin levels go up and the body says, "Oh, I am full," and then it suppresses our hunger. But it's kind of like insulin in that, insulin lowers blood sugar and you go, "Oh, that's good. I should have lots and lots of insulin and it keeps my blood sugar true." But what happens is you get a blunted response to the insulin. And the same thing happens with leptin. So we see this blunted response to leptin, so that even though you have very, very high levels, which should make you very not hungry, patients still have this satiety. And this is released by our fat in our body naturally. And so we need to kind of blunt that response. And what we're seeing in these patients is that the higher their levels of leptin, the more likely they are to have severe levels of osteoarthritis. And then there's a ton of other pro-inflammatory cytokines, which are circulating chemicals that cause injury. And so some of them are involved with healing, but a lot of them are just straight detrimental. And so we really want to have kind of the cleanest diet that we can. And there's actually a great resource on the Regenexx website. If you go to our patient resources and go to the ebooks, there's a free ebook called Nutrition 2.0 written by Dr. Pitts, who is one of my mentors, and he's excellent. The book shows some really great applications of kind of this science that I'm talking about. So it's one of those things that, again, I talk to patients, they say, "Hey, look, we really got to work on the dad bod, or we got to work on getting some of the weight off." And they go, yeah, I know. But it's not taken seriously that it's not just the stress on the knee, it's also the physiology, the environment that the knee joint's living in. And then kind of next step on that, diet and exercise often go together. And kind of the same picture. I have many patients that say, I can't exercise, my knees hurt. And so this was a great study done by a Japanese group that looked at multiple types of exercise. So non-weight bearing type exercises, which would be like the knee extension, the knee flexion machines, knee curls at the gym, versus weight bearing, which would be like your squats, your deadlifts, versus aerobic exercise, like running or elliptical or a bike. And what they found was that patients that participate in a regular non-weight bearing strengthening exercise, like I said, using essentially the machines at the gym, saw about a 30% decrease in their pain. And then each other group, so the weight bearing group saw about half as much improvement of that. And the aerobic exercise group saw about half as much improvement as that. And so one of the best things that we can do is actually get into the exercise. And there's, again, further and further levels of science to this. We can kind of keep peeling them back. One of the reasons that we think non-weight bearing exercise or strength training in general is helpful for osteoarthritis in particular is because it trains the brain to fire the muscles of the thigh in a particular order. And that order encourages stability of the knee. And if you're a patient that's seen a regenerative medicine doctor in the past, certainly a Regenexx doctor, you'll know that one of our core tenets is stability. We need to make the joint as stable as possible. Otherwise, it's like driving on loose struts, and we have all of this extra motion that's going to facilitate further development of osteoarthritis. So again, diet and exercise, things that are non-interventional, things that I can't do for you, are going to be helpful in management of symptoms. This was another study, different group, but it was a very, very large study. And what they did was they actually compared anti-inflammatories like Advil, Motrin, Aleve versus exercise. And they found at the end of the study that whether you're in the exercise group of patients or whether you're in the anti-inflammatory group of patients, your function didn't change. But the majority of the patients that had exercise saw an increase in their relief in pain and compared to the anti-inflammatory group. So this is the other one, I have many patients that are dependent essentially on anti-inflammatories. And so one of the ways you can actually get off of it is by getting into a strength-based training program. And it sounds so counterintuitive. It sounds like I'm telling you the sky is green. But the truth is, if we kind of back off of the anti-inflammatories and encourage some activity, using pain as our guide, again, not saying that, if you're having a hard time getting around, you should train for a marathon, but by doing kind of monitored or physician directed or physical therapist directed exercise, it's actually going to help the pain. NSAIDs we could talk about the entire time. I mean, we could literally spend an entire lecture. Here's some that we kind of pulled up. All of these have publications to back it up. It is not just me saying this. This is entirely all true. And so lots of data showing that NSAIDs make arthritis worse. One of the common reasons why we think that's the case is because it suppresses our natural inflammation process. It really kind of tanks it down low. And the first stage of healing is inflammation. One of the other reasons is that pain is a protective mechanism. And so we think that if we blunt some of that pain, we don't change our biomechanics to adapt to the areas that are hurting. And there's lots of studies looking at this about gait changes on anti-inflammatories with knee osteoarthritis. And so again, probably facilitates progression of the disease more than it actually makes our symptoms better. They're not effective in everybody. Every medication that there is has a non-responder rate that just doesn't respond. And some studies put anti-inflammatories at about 40% non-responder rate. Patients just don't notice any difference whether they're on it or not. There's all of the other things that we talked about that, that's out in the news, the injury to the kidney, injury to the heart, risk of strokes, but the numbers are really quite high. And so, even 1 week can increase your heart attack chance by 50%. There's another study that shows that prolonged use over a month will increase rate of stroke by about 3 times and the rate of heart attack by about 4 times, so 300% and 400%. So again, it's one of those things that doesn't kind of get talked about a whole lot, but really should be. Just because you can get it over the counter at your local pharmacy doesn't mean that it's necessarily safe. And the big one, the thing that we talk about with both anti-inflammatories and steroids, is that it disrupts our body's natural healing process, which then makes patients actually less susceptible for our type of treatment. So moving on, I gotta click here. And then as we kind of get in and we talk about steroids, this was a wonderful study. Dr. McCallendon's group did an awesome job with this. This actually should have been the nail in the coffin for steroid use for chronic musculoskeletal issues, particularly knee osteoarthritis. So basically, this was a group that looked at patients that over a 2-year period were getting steroid injections. The interesting thing is the steroid dose is lower than what I see most patients coming to my practice having been injected with by their orthopedist. This study looked at 40 milligrams of triamcinolone, brand name is Kenalog, and most of the patients that I'm seeing are getting at least 80 milligram doses. So this was half the dose of what we see, but over the 2-year time period, they found 0 difference in the pain in patients that were injected with steroid versus saline, just sterile salt water. So pain was no different at the end of 2 years. And what they found was the thickness of the cartilage was twice less, doubled the rate of cartilage loss in the patients that were getting steroid as opposed to the patients that were seeing saline. And so if you look at the very bottom picture, the last line really should have closed the deal. These findings do not support the use of this treatment for patients with symptomatic knee osteoarthritis. So, those of us that have been in regenerative medicine and have been following this closely, we're like, oh, thank goodness, this should be it. This should end. And what's interesting is I have seen very few physicians that are even familiar with this study, and it was extremely well done. Methodology was excellent, and really should have kind of been it. But then again, there's also groups that are using analgesic, the numbing part of the shot, that are using bupivacaine, brand name is Marcaine, which we know is extremely chondrotoxic, and they're doing incredible doses of it. I just saw a patient earlier this week who had their knee injected with 80 milligrams of triamcinolone and 8 cc's of this extremely chondrotoxic analgesic. And so, but the evidence is out there that we got to stay away from this stuff. And so the thing that I want to spend a little bit of time talking about is one of our approaches that's a little bit different, probably from some of the other groups. And I'm going to give some information, some background information first, and 2 really good studies. And so this is Dr. Hernigou's study. He's a French physician who's been really studying regenerative medicine for his career. And what he looked at in this study in particular was groups of patients, so with similar arthritis in both knees, and they were randomized. One knee got a bone marrow injection inside the joint, where the outside, the articular surface or the touching surface of the cartilage lives. And the other knee in the same patient got an injection not into the joint, but actually into the bone. Both of those bones that we looked at, so the end of the thigh bone and the top of the shin bone, they injected inside of the bone. Didn't go into the joint at all. And what they found was that pain relief and level of function were better in the group that received the inside the bone, or an intraosseous injection. And the group that only got the injection inside the joint had about 3.5 times as many knee replacements over the course of the study, which was 15 years. So very big study, lots of patients, and showed that if we're treating just inside the joint, we're more likely to go on. to require knee replacement surgery. And that's one of the things that kind of makes our group different. There's lots of groups, and I hear it all the time from patients that are saying, oh yeah, I saw Dr. So-and-so at this group. They said that they do exactly what you do. And no, that's not true. We're following the science and doing kind of the best that's available. And so we treat inside the bone as well as our standard of practice for moderate to severe osteoarthritis requiring stem cell treatment or bone marrow based treatment. And so that's kind of what we've been doing. And then what's interesting is the patients tolerate the procedure extremely well. And that's the bottom line here. Patients in this study, knowing, again, that one knee got injected inside the bone, one knee got injected inside the joint, preferred the inside the bone injection and felt better relief with that. So this is kind of a hallmark study and really changed the way that regenerative medicine physicians should be thinking about managing osteoarthritis. And oftentimes this comes across as somewhat counterintuitive as well. So why are we treating the bone? What's the point of treating the bone? Well, that's where the cartilage gets its nutrients from. And we know, as we've talked about in some of our other lectures, that anytime there's chronic inflammation, chronic injury that the body's trying to repair, it's using the local stem cells. We have them in all of our bones. And so particularly with knee osteoarthritis, the top of the tibia, the bottom of the femur, those stem cells are all going to get used up. And we have biopsy studies showing that they are lower than anywhere else in the body in patients that have chronic issues like osteoarthritis. So not only are we creating a huge stimulus to really the nutrition source for the cartilage, but we're also repleting or reinstalling the stem cells that should natively live at the end of these bones. And that's why we think the outcomes are so good with this. Dr. Hernergy went on, same group, different study, but what this one was looking at was they took patients that were scheduled, so scheduled for bilateral knee replacements. And so these are not patients that, I mean, the surgeon said, yes, you need your knee replaced, or, you know, I'm going to see you in a couple of years and it's time for knee replacement. These are patients that had surgeries on the books for bilateral knee replacement. And they said, well, wait a minute, what if we take one of those knees, because it's typically done as a staged procedure. You do one knee first, wait several months, do the second knee for bilaterals. They said, well, what if we took one of those and we did a bone marrow treatment on it inside the bone as opposed to inside the joint? And what they found was that of those patients, again, these are patients, yep, I'm ready to go to the operating room, here we go. Only 1 out of 5 ended up saying, yeah, I should have the surgery. And what's really interesting is that the length of duration, which in this slide, I'm calling incidence. So what is the incidence of these patients requiring, ultimately needing to go on for knee replacement, is about the same as a patient that had a knee replacement and is going to require a revision surgery. So its outcomes are just as long as you would expect then from knee replacement. And so this is person year, so per individual per year, there's essentially a 1% risk of that patient needing to go on and getting a knee replacement. But if you've had a knee replacement, there's about a 1% risk per year that you'll need a revision surgery. And so it was basically identical in the study. And this is huge data. And again, you know, if you're a physician that you're seeing, whether it's pain management, PM&R, orthopedics, sports medicine, they may not be up on this data that really shows excellent outcomes by treating inside the bone. And we still treat inside the joint. We still treat all the supporting structures as well that play into the kind of the importance of keeping the knee healthy. And then, you know, I just wanted to kind of touch on this. This is a little bit different from what we've been talking about. And man, this title like is headache inducing, right? Genome-wide DNA methylation profile. I'm done at that point. You can't keep going, right? So, but when you read through this, it's a really fascinating study because I get a lot of patients that ask me, hey doc, do any of your treatments work for bone-on-bone osteoarthritis? And absolutely. What this study shows is that our bones, our joints are working incredibly hard as we develop osteoarthritis. A lot of times we say, oh, well, my knees did a good job. That was a good try. Now they've kind of given up. It's the exact opposite. And this is a part of science that's called epigenetics, meaning we can change our genes that are expressed based off of our environment. And so as the knee starts to become more and more irritated from the osteoarthritis, we actually turn on more of our genes that are useful for creating cartilage. So we actually ramp up that process. And so now if we kind of add fuel to the fire, or we give those cells essentially a Red Bull in the form of bone marrow cells or stem cells, Now everything's primed, everything's ready to go. And what we found in our registry data, which we've been keeping since 2005, is that our outcomes are the same for mild, moderate, and severe osteoarthritis when the treatment is appropriate. And so mild and moderate osteoarthritis of the knee responds very well to platelets. Moderate to severe responds very well to bone marrow or stem cells. And so, and there is overlap in that middle, and that's often a discussion that I have with a lot of my patients as far as what's best for them. Okay, so interesting stuff here. And then what's our data? This is all public. If you've ever been to our website, you'll know that we keep all of our data public. And so in general, you can see two different graphs here. The graph up top is percent function is rated by our patients. The graph on the bottom is the degree of pain on a 0 to 10 scale. And then kind of the left to right axis of the graph shows the time at which this is. And this is specific for knee osteoarthritis. And this is also for all patients. So these are patients that are treated with platelets. These are patients that are treated with bone marrow cells. And in general, what we're seeing with a single treatment is about a 50% reduction in pain, 50% improvement in function that lasts about 4 years. And this parallels what Dr. Hernegru's group in France is seeing as well. So again, all of this is kind of public information. So you can go on our website, you can play around. If you have a complaint from a different body part, you can select that on our results website as well. And you can kind of see what the outcomes look like for those areas too. So I hope this has been interesting. I hope it has been informative. We covered a lot of different studies, and the point being that there's wonderful evidence out there for different types of treatments that certainly we perform, whether it's platelets or bone marrow cells, and we can help patients that have even more severe forms of osteoarthritis. So certainly if anyone has any questions, you're more than welcome to throw them down into the chat. I am going to end my screen sharing. And it looks like Jonathan, thank you, says thank you. You are most welcome. It's my pleasure. I love talking about this. I love doing this. This is, certainly my passion in medicine for sure. So thank you for joining me. I did have one question that was emailed in. So as I pull that up here, this is from Rebecca, who I don't see Rebecca in the chat. She may have left, but she says, Dr. Urbanek, quick question for next week. I won't, there's some demographics, I won't give that out. Avid marathon runner, noticing increasing pain, having clicking and popping type sensations, which would be best, platelets or bone marrow? And so this is a really good question for a couple reasons. So I was actually an avid runner myself, and I can understand the mentality of how do we keep things going. The popping, clicking, catching may be benign. So most of the time that we're having kind of that crunchy sensation or crackling in the knees is often benign. And there are wonderful studies that showing that as you hear popping and grinding, it's not worsening of the underlying osteoarthritis, it's a mechanical effect. So that smooth, healthy cartilage is like a kind of quiet lake. It's the water is still, it looks like glass. And so the two edges glide against each other very, very smoothly. But as you get osteoarthritis, you start to get these kind of ripples in there. And sometimes those ripples will line up like gears. And then when you move, you get kind of a cracking effect. And so we don't think that that's harm. One of the things that if it's locking, meaning the knee gets stuck and stays in a position, that's potentially the meniscus and something that needs to certainly be evaluated. And in regards to your specific case, that's something we'd have to have an evaluation and kind of talk about as far as what's the degree of osteoarthritis, what are your goals, and kind of have more of a face-on-face. So unfortunately, I can't give you a great answer online as far as which would be better for you, but something that I think we could certainly address in person. It looks like we have a couple questions. So Wendy's asking, what can I expect for the recovery following platelet procedure? In regards to specifically to the knee, knee tends to be really well tolerated. And so it's usually a couple days of soreness. We can provide a little bit of extra pain control, pain type medication to keep patients comfortable, that you're going to be walking around sore, a little stiff, maybe a little swollen, but after a couple of days, it'll kind of go back. And then you're going to see some kind of a slow gradual improvement. So Wendy, if you saw on the graph, if you look at where most of the improvement takes place, it's within about the first 6 months. And there are patients that do take about that 4 to 6 month period before they really get relief. So on my side of things, as I'm looking for outcomes with my patients, I tell all my patients, I want to see what your outcomes are at 6 weeks. As far as, did I move the needle for you? Did I make any degree of improvement, whatever that might be? And then I check in at about 6 months, and now I want to know how much improvement did I make? Because at 6 months, I know that's going to be 85% of whatever that patient's ultimate outcome is. And so that's how we kind of gauge treatment, and whether we have to do, if we were doing platelets, maybe we go to bone marrow, or maybe we do some other things to kind of get them moving along. But that's a pretty typical response for platelets. So it is quite well tolerated, particularly in the knee. Our next question is from Rebecca. She says, where do you harvest bone marrow cells? Is that painful? Yeah, wonderful question. So the data supports harvesting from the back of the pelvis in the iliac crest, highest concentration of bone marrow cells. And we do a multi-step approach, which is something I could do a webinar just talking about how our approach might be a little bit different. And so we actually go to multiple sites across the iliac crest and harvest a small amount of bone marrow from each of those. And what we find is we get a much higher concentration in bone marrow as opposed to the more traditional approach, which is a single pass kind of down the whole column or hallway that exists of bone marrow in the pelvis, and pulling lots and lots of bone marrow from a single site. We also find it to actually be better tolerated. So it is not terribly painful for the majority of patients. We actually studied it at our headquarters at the Centeno Schultz Clinic. We found about 85% of patients rated it as mild pain or less. And so very, very well tolerated. We can use numbing medicine around the site where we do the draw from. And then we also have some patients that request sedation. And so kind of like you would have during a dental procedure or during a colonoscopy, we can do that during your bone marrow if you're apprehensive as well. So we can make it as comfortable as you'd like it to be, but for the most part, the majority of patients tolerate it very, very well. Jonathan has a question. 41-year-old, no cartilage behind patella, bone on bone, both knees. Can injections help, or am I past that? Will not replace my knees due to age. So yeah, great question. I mean, this is what we see all the time. We don't see the easy cases. So this is the kind of stuff that I enjoy treating. And I think likely, yes, we can get you some relief. Now, there's many other factors that play into this, right? So I had a conversation just not too long ago with a high-level athlete who required treatment, and because they're going to continue with their treatment, because they're going to continue with their sport, we discussed that this isn't quite the same as an osteoarthritis knee, where your demand is higher, you're going to continue to put a lot of stress into it. They're going to need treatment typically more frequently. And in kind of the more severe cases with osteoarthritis, we have that conversation as well, that yes, this is more severe. I don't know that I would expect, a 4-year outcome out of this, but there's lots of things that we can do to modify that. So I'm not shying away from bone on bone arthritis. The data supports that we can make a difference, and certainly delay or completely prevent knee replacement. So yeah, Jonathan, if you can certainly call the clinic. We'd be happy to see and kind of discuss further some of the particulars that are involved there. So yeah. I am going to check. I have some in the Q&A, which I have been neglecting. And so, great question from Neela. She says, is it 4 years for bone marrow, 4 years for platelets before another procedure? Wonderful question. And so from our data that I showed, which is available on our website, you can, again, peruse that at your own time as well. That's for all patients. And the reason we use that for all patients is because our data shows that it really doesn't matter the severity of the disease as long as the treatment that we're using is appropriate for that. And so, again, we've combined everyone for that regard. So patients with more mild symptoms are definitely going 4 years with just platelets, and patients with more severe disease are going 4 years, but we're using bone marrow. And so that's why we've kind of added it all together, because the unifying factor for all of that is the idea that the treatment being rendered is appropriate for the level of the pathology. And then Neela also asked, what exactly is the meniscus? Meniscus is kind of a cartilage cushion, C-shaped on one side, a little bit more O-shaped on the other side, and it creates a kind of a fibrocartilage buffer between the two bones as well. It also provides stability. It's one of the reasons we treat that fairly commonly with our treatment. I can certainly do another webinar where we talk a little bit more in depth about the anatomy, but I wanted to focus a little bit more on the treatment this time. But it's a wonderful question, and we can certainly dive deeper into that too. And then a question from Rebecca: it's better to be seen before knees are bone on bone. Yeah, I think so, because I think we have more options available to us. As the osteoarthritis progresses, our options become less, and they tend to be a little bit more aggressive in that, a platelet injection requires just a blood draw from the arm, whereas a bone marrow injection does require an aspiration of bone marrow, which again is well tolerated, but it's more invasive than certainly just a blood draw. So again, getting sooner being seen sooner is certainly better than waiting on it. One of our kind of adages too within Regenexx is, small problems require small solutions, big problems require big solutions. And typically, if we're developing more advanced osteoarthritis, we may be seeing some symptoms in other areas as well that are related to the accommodations that we're making for that. So maybe it's low back pain, maybe it's hip pain, maybe it's opposite shoulder pain because of the way that the kinetics work. So, so yes, it is certainly better to be seen earlier rather than later. So wonderful. Well, everyone, thank you for the great questions. I'm glad you're able to join me today. We'll be back in a couple weeks with our next topic. And certainly, if you have questions or if you have ideas that you'd like to see more information presented on, please feel free to email me. Otherwise, we'll see you in a couple weeks. Take care. Have a great day.